Good afternoon. This is Bariatric Friday. My name is Kemal Erkan. I'm the chairman of American Surgery Center. I'm here with Dr. Isaias Irgau. Dr. Irgau, how are you doing?
I'm doing great, Kemal. It's always great to be back on Bariatric Friday.
Absolutely.
And looking forward to another great session.
We'll definitely make sure it's going to be a good session. So we are trying to kind of continue with our discussions in a different way. Now we have a couple names, patient names who are not real patients, but we want to make sure that we can make some reference points. So today we are going to discuss why patients drop the bariatric surgery process. And there are so many different issues related to that. And going through our case conferences on a daily basis, like today I had to close 3 different cases because we were not getting responses to the follow-ups, but we want to actually just kind of go into more specifics of why this is happening. So before we start this session, Dr. Irgau, if you can just give brief background on the qualification of the bariatric surgery, and then we'll just go from there.
Absolutely, Kemal. That's an important idea. So essentially, bariatric surgery is the treatment of severe or morbid obesity. And what's the definition of morbid obesity? Well, morbid obesity is defined as obesity where the weight is at least 100 pounds higher than where it ought to be, right? So if a person's weight is supposed to be, let's say, 150 pounds because they are 5'5" or 5'6", that would be their healthy weight. If they gain weight and now they are 250 pounds, that is the mark of morbid obesity. Of course, another way to quantify that is to talk about body mass index or BMI. And the BMI that corresponds to morbid obesity is actually 40. Sometimes a BMI of 35 could also qualify a person for bariatric surgery if they have already developed certain illnesses related to obesity, like type 2 diabetes, high blood pressure, or sleep apnea. But that would be the benchmark that we use to tell people whether they are candidates for bariatric surgery or not.
So just to kind of make this follow-up easier for our patients who are watching us, so we have a specific, we have actually 2 patients that we are going to follow them through until the end of the cycle. Most likely we'll be able to, because they're going to be all patient specific. So let's just remember who they were. Katrina is a 37-year-old with BMI 47. And then we have Samantha. And Samantha is a 62-year-old with BMI 42. Samantha is going through, getting through the, she's going to get gastric bypass, while Katrina is going to get gastric sleeve end of their process. But we started this journey with many other patients. And then the ones you see them in red circle, we lost those patients. So everyone started, it's almost like starting the school year, and then some people are not finishing that year. So in a way, and we want to kind of understand why these things are happening. Now, let's start with the most common problems, Dr. Irgau. So why patients drop the program?
Sure. So essentially, what is the program? Well, the program is a period of preparation for bariatric surgery. And because bariatric surgery by itself, the surgery itself is not sufficient for a person to be successful in the long term. People also have to make sure they have some important changes in lifestyle, in the terms of how they eat, what they eat, the level of physical activity they engage in. All those are very important for long-term success. And in order for that to happen, patients need to be educated, evaluated, and prepared by a multidisciplinary team, a team that includes physicians, nurses, nutritionists, psychologists, and all that requires time. And part of the reason bariatric surgery in centers like ours has become so successful in achieving high quality results is because we put a lot of emphasis on this preparation aspect, right, Kemal? So there is going to be a period of time in which patients have to go through this preparation period.
So I
the
think
preparation period, go ahead.
one of the reasons that patients are dropping, one of the main reasons is the process itself, like the insurance are making this so difficult, right? So now, if in Delaware, if it's one of the Medicaid products, like MaryHealth, CHRIAS, or health options, we are asking through the insurance. The insurance is asking 6 consecutive months. So even though a patient is able to finish everything else in like 6 weeks, they have to wait until they finish the nutrition classes, which have to be like you can give them like 6 weeks of nutrition classes in 6 weeks. It has to be 6 months, because it's almost like set up in a way that I understand why the logic is, but it's almost like it's set up in a way that, well, you are not ready and you won't be ready and you change your mind if we keep this process long enough. So for the commercial insurances, this is not the case. So
absolutely, and that's the important difference here, Kemal. The way we look at preparation is as a process that empowers the patient, helps them, encourages them, right? Motivates them. That should be the process, and that's what we want. And yet, the way it is set up, for instance, right now, I, as a physician or a bariatric surgeon, should be able to say, this is how much education we need, this is how much preparation we need, this is how much evaluation we need. And yet it doesn't work that way. We have insurance companies telling us, okay, the patient has to do this many classes of nutrition. They have to do this many classes. They have to spend this much time, as if patients have to earn the right to have bariatric surgery, as if they have to demonstrate something in order to get treatment. This is, if you think about the fact that what we are providing is actually medical treatment, we're saying you have to overcome these obstacles in order to earn this medical treatment. There is no other field of medicine that functions in this way. It is really amazing, right?
So
So when you have an insurance company saying not only you have to do 6 months of nutrition, but they have to be 6 consecutive months, which means that when you start in January and you have to finish in June, if for some reason you couldn't make it in February, you have to start all over again, right? So this is not motivating people. This is discouraging people. And that's the difference between a program that is set up to motivate, empower, and educate people, which is what we want, and a program which is set up to really discourage people. And that's the issue that you and I are facing, obviously.
So, well, that's because I think that was designed based on the stigma that we started talking about in the cycle last couple of weeks. So, because maybe the old-fashioned thinking of morbid obesity is you don't need the surgery. So, if you keep the process long enough, then patients already are struggling, and then they will fail anyway.
Absolutely, absolutely. So not only we have a setup really that is discriminating people because of morbid obesity, but we have a setup that is accepted, although it is in this fashion, right? It's accepted, tolerated discrimination, if you think about it, right? If you have any other illness and you go to your doctor and your doctor recommends a certain treatment, there is no interference which says the patient has to be able to demonstrate XYZ to get this treatment, right? It would never be tolerated. And yet we have such a system and it's also tolerated. And you're absolutely right. It all stems from the fact that there is a stigma associated with obesity that puts people in a shameful place where they're almost afraid to really defend themselves, right? As if they have to defend the fact that they are morbidly obese. We are saying in medicine has really recognize that morbid obesity is actually a disease. It is something that is related to the biology of the person, right? Nobody enjoys being morbidly obese. Nobody enjoys the struggles they have to go through when they are morbidly obese. And yet people are meant to think as if it's their fault, and therefore any type of treatment that is given to them is almost a charitable act on the part of society towards them, right? Which means that any obstacles that we put in front of you for you to get there is okay, because we're giving you charity instead of providing appropriate treatment. And that view of morbid obesity is really at the center of the fact that we have so many obstacles placed in front of patients.
So, Dr. Rida, in some cases, now this is the insurance problem, and then we kind of like we deal with that, right? So there's another issue where commitment is not there in some cases. This is from the patient side, also from some of the programs. Like you and I, we were involved with hospital-based programs for a long time. And what we do with American Surgery Center, it's almost like the service is so personalized in a way that we are not letting the patient making that decision to change their mind and then say that, well, I don't want to go through this because I feel like hopeless. So, because what has been happening with the American Surgery Center versus when we were doing with the hospital programs, our drop rate actually got improved by almost 25%. Mm-hmm. So, because that requires that daily holding hands and making sure that patients are not feeling weak, or they feel like they are this kind of discouraged, because if they don't talk to the right people, it may be so easy to change their mind. So we still fight with the overall treatment of morbid obesity, not just with the surgical, but non-surgical ways. No patient should be leaving without a good plan of morbid obesity treatment from their primary care offices, exam rooms. And that's something that we are advocating, and we are repeatedly talking about these. And I know that at some point it's going to get to that, where patients, they can get medication. In some cases, they can get nutrition consults. So it doesn't have to be surgery, but that whole understanding, again, coming back to the stigma, there's still that like stigma of it. So we need to kind of shake that a little bit stronger, so then they don't feel like they are doing something shameful. Just like we are not, I always use the same example, but when the patient has diabetes, they are most likely on a metformin type of medication. So no one judges them, right? In fact, everyone is trying to remember, oh, did you take your medication? Well, this is the same type of a problem, people. So so I think the programs also need to do a better job in terms of having more people with the right expertise outside of the surgical, outside of the surgeons, everyone else. Like, this is why our care coordinators, they are a lot more successful than hospital systems. So
absolutely. The steps that the patient have to go through in order to be prepared for bariatric surgery, obviously, are complex, right? They have to see a number of specialists, right? For instance, in our program, patients have to see a nutritionist on a number of occasions. They have to see a psychologist. They have to undergo endoscopy, which is a procedure whereby a camera is placed in the food pipe and then in the stomach to evaluate it before the surgery. And of course, the patient is having a nap and a sleep when we do that. But that's a procedure that's important that we have to schedule. Blood test has to be done. X-ray has to be done. Often a cardiologist evaluation needs to be done. Sometimes a sleep study and a pulmonary consult may be necessary. Sometimes endocrinology input, sometimes nephrology, sometimes other specialists may be necessary, right? So when you have such complex interaction of specialists and providers taking care of the patient at different intervals through the process, you need a very, very cohesive program that has a lot of people meeting frequently to guide patients. And that's exactly what we have in our program, Kemal. And as you said, you chair the coordinators meeting every morning, and you go through the patients, and that's what the team does essentially, right? Absolutely. If you don't have that level of commitment in your program, of course, the dropout rate is going to be even much higher, right? And we have obviously this level of commitment in our program because we want our patients to be able to succeed through the process as much as possible, right? The other issue that you have raised, and it's a legitimate issue, is, from the patient's side, are the patients following up sometimes even with this intense hand-holding? Well, sometimes they don't. And sometimes it may be for very, very legitimate reasons, Kemal. And then patients may not be ready for bariatric surgery. As we have discussed in our sessions on Bariatric Friday, Kemal, when patients hear the need for bariatric surgery towards themselves, the first time they think about it, they actually reject the idea. They think, no, this is something I can take care of myself, right? And they struggle through that. And sometimes up to 2 years before the idea of bariatric surgery actually settles in their mind as something absolutely necessary. And at that time, they come and they actually want the surgery the next day. They are that much set in their mindset, right? But patients can come in the program at different levels of conviction about the need for bariatric surgery. And so if they are in the early stages of exploration of bariatric surgery, they may not be ready to proceed, and we will see obviously those patients lagging behind. But as we have remarked in other sessions, what we see is that patients do come back. And when they come back, guess what? They are not any better than when they started. In fact, they will be worse off because over the 2 years, most likely they will have gained more weight and probably developed more illnesses that could have been averted with an earlier intervention. That's why trying to get patients to finish the program is so important, because they are going to be struggling much less if they are able to finish in a timely fashion.
Absolutely. Now, the commitment issue, if we were to, some patients are dropping off because of the high deductibles and out-of-pocket expenses. And I actually just, as you know, I did another interview for one of the healthcare magazines, and it was about our surgery center and how we are actually, how surgery centers can be utilized to reduce the cost of health expenditure. And that actually is kind of was the key in my answers, where this doesn't have to be done in the hospital. So this can be done in the surgery center, which we do. We do about 350 to 375 cases a year. Our patient selection process is extremely well. And then this does help the patient with their out-of-pocket cost extremely. It can be sometimes like so much in a way that when everything is done in the hospital, it's like 3 to 6 times more expensive. So if you do all the process through the hospital system, then you are going to actually pay that much more for each different steps. Like if you are going to a cardiologist who's employed by the hospital system, well, you are paying more. Why? I won't answer that in this session. People follow us on the 2 p.m. session. But if they do their EGD in the hospital, out-of-pocket cost is going to be higher. Getting through the endocrinology and other, the sleep study, it's going to be 4 to 6 times more expensive. So we provide something that is also helping patients on the financial side. And I believe that has something to do with the overall, like the high deductibles and out-of-pocket costs, which we really need to address independently, I guess.
Absolutely, absolutely. So, of course, the level of obstruction that patients face when they are seeking treatment, particularly for bariatric surgery, ranges from situations in which there is no coverage for bariatric surgery, which is something that we have discussed on our previous sessions, to situations where they have to meet such high deductibles that it may be very difficult for them to do that. And of course, we see that in real time, and it's a shame when patients are unable really to get treatment that overall would actually reduce the cost of healthcare for those patients. Because if you're having bariatric surgery and you lose adequate amount of weight, and then you don't need blood pressure medication, you don't need CPAP machine, you don't need diabetes medication, you don't go to the hospital as much, you don't go to the emergency room as much, you don't have issues with missing work as much, all those things actually would add so much more value to the fact that bariatric surgery is bringing, but that is not taken into consideration very often for a number of reasons. I think, of course, there are patients that cannot have their surgery in the surgery center, right? In an outpatient setting, there are patients who may have medical conditions that requires them to stay in hospital for a number of nights after the surgery. And in situations like that, of course, the surgery will be done in the hospital, and that's very important. But there are patients who are perfectly good candidates for them to have outpatient bariatric surgery, which is the setting we have. And there's no question, when you look at the costs of outpatient surgery versus inpatient surgery, there is a major difference there. And I agree with you that would be something that insurance companies should also take into consideration, of course.
So, one of the other issues that I see, the men dropout ratio is a lot higher than women. So why do you think that is?
Well, it is an interesting topic, Kemal, because it's not just seen in bariatric surgery. Generally, there is actually more reluctance in males to seek treatment for any type of disease, Kemal, when it comes to their health. So women tend to be much more attuned and much with their health conditions and seek help earlier. I see that, for instance, in gallbladder disease, Kemal, whenever surgeons know that when they're operating on a male patient as opposed to a female patient, the gallbladder is likely to be much more inflamed in males just because they have postponed the seeking treatment for so long that the condition just gets worse. And I'm sure there will be some degree of that when it comes to bariatric surgery as well. But I'm sure there are other potential reasons as well.
So one of the other reasons that we see is the smoking. For the smokers, this is, I guess, they have to make a choice between smoking or getting healthy. How can we address that problem?
So I think the address here should be all supportive, Kemal, right? I think we should be there to support patients. And the reason I'm saying that again is because I go again to some mandates from insurance companies, which say the patient has to be smoke-free for 6 months, or they have to be this. Well, there's no data to demonstrate that you have to be smoke-free for 6 months for you to be able to have bariatric surgery. In fact, most of the data suggests that anywhere between 6 to 8 weeks is absolutely appropriate for somebody to have quit before they can have bariatric surgery in a healthy manner, right? So this issue, because it's an important issue for us as surgeons, and because it's imperative that the patients actually quit smoking before surgery, we address this very early in our interaction. So once we confirm that the patient is a smoker, we let them know, and we actually guide them to areas where they could have support for them to quit, right? Again, it should not be a punitive thing. It should be supportive. In other words, we should be there really to lend a hand and also make patients understand. One of the reasons patients are reluctant to quit smoking, for instance, in the setting of bariatric surgery, is because they feel that if they stop smoking, they will gain weight. Well, that is true. There is some truth to that, right? Because patients who smoke tends to suppress their appetites. Therefore, it kind of controls the weight to some extent. And once they stop smoking, appetite will go up and they will gain weight. Well, we can work with them on the weight increase issue, right? We can work with them because they are getting nutritional counseling. They are getting the knowledge that they need to maintain their weight or else at least come down on their weight through the process. And importantly, we have specific diet programs before the surgery that we incorporate in the program that will actually allow them to lose some weight as well. But unless we address all these concerns, it's going to be very difficult for patients to stop, right? I mean, as we all know, stopping smoking is by itself one of the hardest thing anybody can try to do, particularly for long term, for people who've been smoking for a long period of time. And if to that we add an issue where, this becomes more of a, punitive thing, then it becomes even harder for them. And it's likely that they will drop out from the program as well. So yes, it's a challenge for them to stop smoking. Yes, smoking must be stopped before surgery, but we can address this in a supportive way by giving really patients options and tools that will allow them to succeed.
So now, one of the other issue, which is not now, it's not the discretion of the patient or the practice, but some patients do have heart disease that's preventing them to have this surgery. Can we talk about that a little bit?
Absolutely, absolutely. So one of the greatest advances we've done in bariatric surgery over the last couple of decades, Kemal, is for us to recognize that for us to be able to show the effectiveness of bariatric surgery, we also had to show the safety of bariatric surgery. And the safety of bariatric surgery has improved greatly because we have a preparation period which really evaluates the patients for possible risks during the time of surgery. And one of those is obviously evaluation of their heart health, right? And many patients may not have symptoms, but they may have underlying heart disease that may be uncovered at the time of the evaluation. So patients may undergo an echocardiogram that may show some abnormalities that may lead to other tests, including cardiac catheterization, or even we've had patients who've actually had treatments with stent placement as issues were discovered through the surgery. Now, if a patient has a stent placement or they have some other treatments, the bariatric surgery may have to be postponed for a few months afterwards until clearance is given by the cardiologist. This could apply to other conditions, for instance, if there are patients that are found to have liver disease, kidney disease, and this need to be addressed, and that address may require some period of time. Obviously, that is something that is important for us to be able to do. Occasionally, we do find some abnormalities when we do endoscopy that requires some treatment before the surgery as well, and that can obviously push the surgery time. But that is all important. That's why we have the preparation. That's why we have the program, is precisely because we need to address these issues before bariatric surgery, so bariatric surgery can be undertaken in such a safe manner. If you think about it, Kemal, if I had told one of my teachers in medical school that I would be doing complex intestinal surgery like bariatric surgery on patients taking me about 1 hour, 15 minutes, and then for patients going home during time that day, my teachers would never have believed that. These were surgeries that were done over many hours. Patients had to stay in hospital for a long period of time. The morbidity, the mortality was very, very high at that time, right? But fast forwards 25, 30 years later, we have reached this level of effectiveness and safety that made bariatric surgery obviously much more accepted now, and rightly so.
So, one of the other issue that I see, Dr. Ergau, the actual documentation, history of weight gain or weight, the morbid obesity problem, and that actually is also kind of like interesting, where it just brings me back to the same issue. So that means the patient didn't become morbidly obese overnight. So this is a process, right? So that means these patients did not have their annual wellness visit, the physical. So because if they did, and also if they did, that means the morbid obesity or the weight gain was not documented properly, because that's still like a big percentage of the patients are suffering from not having the proper documentation prior to starting the bariatric surgery, and that can be 2 to 5 years based on the insurance and employer plans. So that also is kind of like, like when we kind of go back to the same issue from different angles, like it just takes us to the same problem. Like this needs to be, morbid obesity needed to be treated at the PCP level. No patient should leave their PCP offices without that proper plan, because if you have that plan and if you document it, so that would take care of one of the admin type of issue where no one should be disqualifying because they don't have 2 years of morbid obesity documentation. So that just
Absolutely. When you look at the definition of obesity as a disease, Kemal, there are two important words that are attached to it: progressive and chronic, right? It is progressive because it doesn't get better. It gets more and more and more. It progresses, right? The obesity becomes worse, right? This year, the patient will have gained more pounds compared to last year. Next year, they will have gained even more. So the disease is progressive. And it's chronic because it goes over a long period of time. Mm-hmm. And most patients that come to bariatric surgery will have been struggling with weight really for a very long period of time, stretching usually a decade or longer, Kemal. So you're absolutely right. The issue, the fact that obesity is not addressed earlier within the framework of the health of the patient is a problem, obviously related to viewpoints we have about obesity, as you all, continuously you make a case in the sessions.
No, absolutely. That's that is kind of like that's the case. So, but in terms of Katrina and Samantha, they are continuing with the program. They may be hearing different things from people who are who may be family or friends, but they just listen to their own doctors. The other issue that I see is like when we do these sessions and then how much information we give out, every time someone is watching these, they probably know more about what we are doing, because there's this unknown of whether or not this is the safe procedure. Some patients are copying because they are scared. So when we tell them 99.9% of our patients are discharged same day, 8 hours after their surgery, and people are like looking at me like, oh my God, you're just sending people home? Like, so that's just the, ignorance because they don't know. So, and I was one of those people, and then you remember in the beginning, like, do we need to send them home? So let's keep them one more day. So that's because how we were trained. So that is the lack of understanding and lack of knowledge, lack of access to the right information. And I think we are doing the right thing. So just like making sure that everyone knows patients are able to go home same day. This is not anything more complex than, in terms of clinical risk, it's not more complex than gallbladder surgery. In fact, with the appendix and gallbladder, it happens in some emergency cases when people may die if they are not in the hospital in a timely manner. But this is done through the selection of the entire team is being done. Entire team goes through each step one by one, and so many people are watching, and we are able to actually get the patient to the safest point. Because if it's not safe, we will be the first one who will tell them this is not going to work out for you. So, like the smoking problem, drinking problem, substance abuse. So we do weed them out as we go through the program. But I still see some benefits for them starting the program, because then maybe they can at least follow through the bariatrician, follow through the nutritionist. This needs to be, again, treated. So people, like when I say this, and I won't get tired of saying this, and I will say it again and again and again, it needs to be taken seriously as a chronic illness, as it is a chronic illness. And the treatment of morbid obesity should start in the PCP offices. So then as they hear more about it, Dr. Erkan, like the reason I'm kind of like emphasizing this again and again. So this week, we had some conversation with some PCPs, and there's still that little like shyness, like, oh, well, we don't want to hurt patients' feeling. Well, how are you going to hurt the patient's feeling? So if patients have diabetes, their A1C is 10.5, what do you do? oh, well, we start them right away with like this, and then they have to go to the end. I'm like, well, it's the same thing. So if they get upset, it's because you see your perception or your approach is already making me uncomfortable, because if my doctor is not comfortable with if my doctor is not comfortable with what they're telling me, look, I mean, that's not going to work out. So my doctor needs to, well, don't tell me that I'm fat, but tell me that I have morbid obesity. There's a difference. Because if you say that I'm fat, then you're insulting me. But if you say that I have morbid obesity, then I know that I have a chronic problem. So that doctors can actually help us better understand at the primary care level, at the base, in the hub of the patient care, that can start right there. So then, okay, so your BMI is 42, Katrina is 47. And if she was Dr. Valencia's patient, so she didn't leave our exam room without the proper morbid obesity treatment plan. That's what we are trying to do. We are trying to make that standard. So then they hear this from everyone else at the same time, in different times, but with the same level of clinical importance, so that this is not something optional. So these people need help, and we'll keep doing this.
Absolutely, absolutely. Kemal, one of the privileges of being a physician is that, as a physician, one is let into the most private and secret places of the patient, because they open up, right, to talk about their health, to talk about issues that are affecting their health. And that is a privilege for physicians, right? At the same time, we owe it to our patients, really, for us to be able to raise issues that are going to affect the health of the patients, right? And of course, there are ways of doing this. It's not a question of castigating the patient and punishing them or judging them because of the obesity issue, but the obesity issue can be raised in an educational way, Kemal, when we relate it to the health problems that the patients are suffering, whether it's joint pain, back pain, diabetes, heartburn, headaches, gallbladder problem, sleep apnea, high blood pressure. When all these issues are addressed individually, it becomes ineffective. But when we are able to relate them to the fact that the patient is overweight, the patient is obese, the patient is morbidly obese, that connection sometimes can do wonders. It is possible, Kemal, that many patients may not be aware at all that their diabetes is related to the weight, that their high blood pressure is related to weight, that their sleep apnea is related to weight, that their gallbladder problems or heartburn or other ailments that they are that they are afflicting them are related to weight. They may not know that. And that enlightenment actually can open the door for the discussion to happen at that time, and then for the patient to buy into those recommendations as well. And I agree with you completely. For instance, when you say that even when patients are not ready for surgery, it's important for us to show them other avenues of treatment, right? Whether it's by getting them to see the nutritionist, by them getting to see our bariatrician for medical weight management. These are important avenues, because at least even if patients are not able to lose a substantial amount of weight, they may be able to keep some control on the rate of increase of their weight. And that is very important, but also it adds more knowledge for them as well. So definitely that's what I use. I mean, I have patients who come to the office and clearly they're looking for options. They're not necessarily committed on the idea of bariatric surgery. And I understand that, Kemal. In fact, when I present patients with options for treatment, I present all the options and I tell them really what the outcome is of potentially of all the issues, right? And patients, as you said, may not be ready for surgery, or they may not be able to go through surgery because of issues of insurance and other things. And keeping the non-surgical options open, obviously, is critically important.
No, absolutely. That is, more information, standard information is given to the patient from different resources is the key. So, and that's one of our goal is by making these sessions available, having discussions with our accountable care organization providers, with other health organizations, goal is to make sure that everyone understands that this is an available, most viable option for those patients who are dealing with morbid obesity, and we are here to help. So, Dr. Erkan, thank you so much for joining me.
Thank you, Kemal. That's great. Always to be here.
On Friday again. Thank you so much.
Thank you. Have a great weekend, everybody.